The presenting health professional has made every attempt to protect the privacy of patients whose cases are discussed, and we ask that you respect that privacy. If you have a colleague that would be interested in viewing this video, please send a request with their email address to grandrounds@rocklifemed.org, and we will send them the link. Thank you.
Hello, everybody. Welcome to Lifestyle Medicine Grand Rounds, sponsored by Rochester Lifestyle Medicine Institute and IHA in Ann Arbor, Michigan. It's so great to see all these little rectangles popping up from all over the world. We're going to give you another minute or so to come in. I've got some interesting statistics, though. We have registrants from 26 different states and 5 different countries, including Canada, the Philippines, Singapore, France, and India. So it's like people are still trickling in. And I'm going to put up my agenda here. Let's see how to click the share button. Oh, and by the way, I'm Dr. Ted Barnett, the president and founder of Rochester Lifestyle Medicine Institute. It's so great to have everybody here. Let me just tell you about our panels for tonight. I'm going to do a formal introduction in a minute, and we're very excited to have you here. Let me just put up the agenda for tonight. So tonight's case, which will be presented by Dr. Wagley, is addressing what matters the most for a frail older woman with multimorbidities using lifestyle medicine tools. And we're co-hosting, as I said, with Rochester Lifestyle Medicine Institute and IHA. And let me get my buttons to work. Our agenda tonight, we will have about 5 minutes for introductions. The case presentation will take about 40 minutes, including some poll questions of the audience. We're going to have audience Q&A from 8:15 to 8:30. At 8:30, we will officially end, and you will receive an email that will take you to a survey, and then you'll be able to download a PDF worth 1 CME of credit, which is all free because we have very generous donors. And then we're going to move into the lobby. We found that there are often interesting conversations continuing that some often take a little more than we have allowed for. So we may spend 15 minutes or so having a little more of a conversation. If you're interested in partnering with us to empower your patients, we have a number of standardized programs which are certified by the American College of Lifestyle Medicine to help build motivation and competence. The 3 programs are our very own Jumpstart program, the 15-day whole food plant-based Jumpstart, the LIFT project, and Pivio, which is the direct descendant of the Complete Health Improvement Program. We run a number of free CME courses. If you're interested in doing a CME with patients, this is a unique program that we run. You can actually participate in the Jumpstart or in the LIFT project and receive 10 CMEs. And again, those are free because of our very generous donor. We also are asking that you respect the privacy of anything you learn about in this case. Dr. Kamal Wagley is an assistant professor at Indiana University and an attending physician at Indiana University Health Physicians. He attended medical school in Kathmandu and completed his residency at Baylor College of Medicine. He received his master's of public health at the University of Texas School of Public Health. He's board certified in family medicine, geriatrics, and lifestyle medicine. His clinical focus has been in primary care, geriatric consults, and post-acute and long-term care. His scholarly work is in medication safety and caregiver support, and strengthening interdisciplinary work in primary care for older adults. His passion is in healthy aging, high-quality patient-centered care, and age-friendly health systems. He is also the board member at large at Indiana Geriatric Society and a committee member at Public Health Education of American Geriatric Society. Dr. Michael Klaper, who may need no introduction to many of you, is a gifted clinician, internationally recognized teacher, and sought-after speaker on diet and health. He has practiced medicine for more than 40 years and is a leading educator in applied plant nutrition and integrative medicine. Just as an aside, we used Dr. Klaper's book when we were raising our children. We became vegan back in 1991, and Dr. Klaper was there helping us, at least in print. He graduated from the University of Illinois College of Medicine in 1972, served a medical internship, and received training in surgery, anesthesiology, and orthopedics in British Columbia, and trained in obstetrics at the University of California Hospitals. I'm going to skip through some of this, but he has worked at True North, which specializes in the therapeutic fasting and health improvement through a whole food plant-based diet. And most importantly, he has served as an advisor to the National Aeronautics and Space Administration Project on Nutrition. An advocate of plant-based diets and the end of animal cruelty worldwide, Dr. Klaper contributed to the making of Food for Thought and the award-winning Diet for a New America movie based on the book of the same name. He's been featured in 2 other documentaries, What the Health and Cowspiracy, and he feels the most important work of his career is unfolding now in the Moving Medicine Forward initiative, traveling to the nation's medical schools to educate students on using plant-predominant nutrition and positive lifestyle changes to truly heal their patients. So welcome, Dr. Klaper. I've got what's going on here? There we go. Our regular panelist, Dr. Robert Brakey, board certified in family medicine and lifestyle medicine. He's been a family physician in Ann Arbor for 36 years and serves as the medical director for IHA's William J. Folletti Center for Lifestyle Medicine, as well as the chair of IHA's governing board. He's also on the board of directors for 2 national organizations, Plant-Based Nutrition Support Group and PPOD. He has a special interest in employing lifestyle medicine approaches for disease reversal. And our other colleague, Melissa Sunderman, is board certified in internal medicine and lifestyle medicine, has been practicing medicine for over 20 years and is starting a new practice at Canyon Ranch, Lenox. She has training in integrative medicine, completed a professional training program in mind-body medicine, and is a member of the Academy for Eating Disorders. Her clinical interests include lifestyle medicine, plant-based nutrition, food as medicine, and sports nutrition. She's an avid endurance athlete and is outdoors as often as possible. Dr. Friedman is not with us tonight. She's our course wrangler, and she's a geriatrician in Rochester. And that's me. I am an interventional radiologist and the founder and president of RLMI. And now it is time to turn the screen over to Dr. Wagley, who will be talking about addressing what matters the most for a frail older woman with multi-morbidities using lifestyle medicine tools. And there he is. Would you like to share your screen? Welcome, Dr. Wagley. Welcome, Dr. Brakey, Sunderman. Welcome, Dr. Klaper. And here we go. Take it away.
It's great to be here. Thank you. So I'll walk you through the through my case, and look forward to having a very rich discussion today. I have no conflict of interest to report, and as mentioned before, the patient's name and PSIs are removed for presentation, and patient provided verbal consent for the presentation today. This clinical setting is outpatient geriatrics primary care clinic, where there will be initial assessment of patients consisting of comprehensive geriatrics assessment. Physician routinely does geriatrics 5M assessment, which we'll be talking, and physician also routinely assesses lifestyle vitals for the patients. So just a quick introduction for if this is a new term. Comprehensive geriatrics assessment includes assessment of a functional status of a patient, which means assessing their activity of daily living, instrumental activity of daily livings, their vision, hearing, dentition, their nutrition, cognition, home safety, gait, balance, falls, screening for common geriatric syndromes like incontinence, depression, dementia, advanced care planning, and a team huddle with interdisciplinary team, including nurse, social worker, pharmacist, are also integral part of comprehensive geriatrics assessment. So you can see it assesses function, ability, mental health, cognition, support system, and disease severity and comorbidity. I'd like to just highlight the framework of age-friendly health systems. This is an initiative of John A. Hartford Foundation and Institute of Healthcare Improvement in partnership with the American Hospital Association and the Catholic Health Association of the U.S. It basically highlights that for older adults, it's really important to know what matters, knowing and aligning care of their specific health outcome goals, care preferences, including not only limited to end-of-life care, but also across all setting of care, like in primary care, post-surgical care, inpatient, using medication that are age-friendly, that do not interfere with mobility, mentation, assessing mentation, identifying and treating depression, dementia, delirium across all the settings of care, and also assessing mobility, making sure they are safe at home and community. So in American Geriatric Society adds fifth M, multi-complexity, just to highlight that every older adult, as they age, there's more chances of accumulating a lot of chronic conditions. And we assess how frail a person is by doing some frailty index, understanding how different diseases are present in the patient, how the social support is. So multi-complexity really is a sort of a framework which also includes what matters, mobility, medications, mentations. This is also the framework in Canadian Geriatric Society, and this has been more of a part of a lot of geriatrics program through the country. And 5 M's and lifestyle medicine, I would like to just show how they are integrated. So we know that in lifestyle elements are common contributors to diverse chronic diseases, offering lifestyle interventions for non-communicable chronic disease. Optimizing social interactions and coping mechanism and cognitive health is so important. Fermentation, encouraging physical activity and mobility are connected, and utilizing food as medicine, produced prescriptions are integral part of medication prescription and safety. And we focus on goals, preferences, adding meaning and purpose to life, which is a integral part of lifestyle medicine pillars. So you can clearly see the geriatrics principles and lifestyle are so much philosophically aligned. With that quick background, I want to introduce my patient. She's 85-year-old, Mrs. Hoosier. She lives by herself in a single-story home. There's 3 steps to get into the main level, 7 steps to go to the basement, where she has her washer and dryer. She's divorced, and her ex-husband had passed away. She has 4 children. 2 of them are in town. All stay in touch. She has high school education and worked as an elementary school secretary for 36 years. She has a Jack Russell Terrier dog. The way I'm introducing the patient, just to give an example of how unique my patient is, and it also reflects some of the living condition, home safety, social support. So I really like the introducing a patient with some of this context. And our healthcare team, when I first saw the patient, was a primary care team, chiropractor, and a nephrologist. She had a hypertension, chronic kidney disease with secondary hyperparathyroidism, chronic insomnia, chronic back pain, osteopenia, diabetes in family history, and cancer in family. I saw her first in August 2021. These are the medications she was taking when I saw her. She said she did not have acute concern, but she wanted to know, first of all, before I even saw her, is if I'm okay with her seeing a chiropractor on a regular basis. And she also wanted to make sure, and if that is okay, the second question was to make sure the medications are okay. And she reported chronic issue of pain. She had upper back, neck pain, and she gets adjustment with chiropractor every month. She has chronic insomnia. She takes medication as listed here. Review of symptoms. They're positive were urinary urgency, intermittent urge incontinence, nocturia. She mentioned bowel movement has altered. She said she will have regular bowel movement for several days, but she never feels a complete evacuation. Her stool consistency was semi-solid, but once in a while she will have a bowel incontinence, and she is so afraid of that event that it limits her outdoor activities. She's fully independent in her function, ADLs and IADLs. Medication, as you see, she has some acetaminophen to take as needed, ibuprofen rarely, amitriptyline, 20 milligram at bedtime, amlodipine, losartan, vitamin D, and the supplement MakeU Health once a day. I did a lifestyle history and vitals, which are measuring pretty much lifestyle pillars. So she used to go to LA Fitness, a fitness center, but she stopped since pandemic. And she does acknowledge that she is not being physically active. This is her dietary history. I did a quick scope of how her diet is in a 24-hour. Her breakfast is around 9 o'clock. She was very proud that she's eating a healthy breakfast bowl, prepackaged, or 2 egg omelet or scrambled eggs to make sandwich. Lunch is around 1 to 2:30. So it's chicken noodle soup from a can or a hamburger. She said she eats snacks for dinner: Cheetos, cookies, chips, pretzels, chocolates. Her beverages, she drinks 2 cups of coffee in the morning, 3 glasses of cranberry juice throughout the day, 2 glasses of water, 1 cup of herbal tea at night. She says she needs to take prescription medicine daily to get some sleep, but her perceived sleep quality is still poor. And obviously she sleeps about 5 hours. She denies having much stress. Since COVID, she has been doing virtual church, and she has not been meeting friends as she used to. And her children, family who are local, they were not enthusiastic about COVID vaccine, so she's actually even not meeting them, just staying in touch through a phone. She does not smoke and drink alcohol, and her body mass index is 24.5. So poll number 1, which of the lifestyle pillars is the most important to address for Mrs. Hooser? Healthy eating, physical activity, stress management, relationships, sleep, and substance abuse.
All right. Okay. I think it's time to reveal the poll. What have we got, Bob? All right. Dr. Clapper, what do you think about those responses?
Okay. Everybody, most 2 out of 3 went for healthy eating. Yes, there's no question that diet certainly could use a lot of improvement. But she's made to 85 eating that stuff, so she doesn't seem to have, well, she's got high blood pressure, and it's not doing great things for her vascular system. I'm more concerned about her relationships, that she's withdrawing from her family, from friends, etc. Actually, I voted for relationships, but it's hard to argue that Jimmy Dean omelets are probably not the best way to start your morning. So I've got no complaints with healthy eating either.
Dr. Sunderman. And you're muted too. All these experts.
God, you'd think this is the first time we're doing this. So I chose healthy eating, but I completely agree with Dr. Clapper and what we're learning about loneliness, particularly as we get older. Vivek Murthy, the Surgeon General, now has an advisory that came out about the health risks and morbidity, mortality associated with lack of relationships. And this lack of relationships and loneliness, she used to be going to the gym. She's not going to the gym. So now that's affecting her physical activity. We know that there's increased risk of atherosclerosis and heart disease, and even increased risk of MIs and dementia with loneliness. But I think if you could fix something most easily, just by getting maybe a little bit of fiber into her diet, that might help with her GI, with her stool issues and things like that, and try to boost up that gut microbiome, because in that, I think maybe her only fiber was maybe some of the bread or maybe the noodle in the chicken noodle soup. But so I think that if we wanted to make small little changes, 1% better, I think, with the dietary pattern. But I agree with Dr. Clapper that the lack of social connection and the loneliness is a big risk factor.
Right. Thank you for that. Dr. Brakey.
I'm not muted.
Good.
Well, I also picked healthy eating just to, but again, it's close. My second was the second highest vote was sleep. 5 hours is not enough. That's going to interfere with her kind of repair time in her brain and her body, her bones. She needs the rest to help build. And obviously the two together, healthy eating, which as Melissa implied, and means more fiber, more beans, more fruit and veggies, whole grains, foods that will nourish not only her, but her microbiome, so that she'll be in a balanced state and a state of anti-inflammation instead of, as Dr. Clapper calls it, the red tide coursing through her veins and arteries. So yes, I agree with the kind of top two picks here as the most important to focus at first.
Great. All right. How did they do, Amal?
So when I saw her, I really wanted to move into her house or take her to my home and just work on all the pillars. So many things to work on, but I think there is a significant social isolation in pillars. So we pretty much worked on a few of those. On some areas more intense, like definitely diet was a little more work because she was very receptive, very motivated to change, to work on the health. She really wanted to hear how can she improve her overall health without taking prescription medicine. So she was all ready to change. So I think that we definitely worked on eating and some physical activity as possible in our safe home scenario. But we also, our clinic also had a more close support. We contacted a chaplain who could do some outpatient in touch follow up with our patients. So working on some staying in touch to provide support. And definitely to work on sleep, and sleep was also very important. Next, I'd like to quickly reveal how was her geriatrics 5M. She said what brings joy to your life. She said her family is the one, is important for her. And when I asked her what concerns her the most about her health, her answer was mobility. And she screened for mild depression. PHQ-9 was 11. A cognitive assessment, she did pretty good. We did a Montreal cognitive assessment test. Medication she did was taking high-risk medication with higher anticholinergic property, so that we definitely need to work on. Mobility, we watched how she walked, and we did a timed up and go test. Very easy to do in clinical setting. It was 18 seconds, normal is 12. She didn't use any assistance to walk. If you look at frailty score, she falls in a moderately frail categories and review all morbidities. So we did this Montreal cognitive assessment tool for cognition and timed up and go, very easily accessible for anyone to use in their clinical practice. So poll number 2, which of the 5 M's of geriatrics would you plan to address first in Mrs. Hooser? What matters? Medication, mentation, mobility, multimorbidities.
All right, everybody in the audience, if you could please pick one here. All right, Dr. Clapper, what are your thoughts? It looks like
right. Yeah, I was down at the bottom along with 27% of folks here. As far as what matters, she seems to be fairly mobile. She's concerned about mobility. Her tug test's a little bit long there, but at least you can get out of the chair and move around. I was more concerned down at the bottom with the multimorbidities. She's on amitriptyline. She's clearly got an element of depression going on there. She's got some bowel and bladder issues as well. She's flirting with hypertension, so she's on amlodipine. She's got polypharmacy happening in the background there, and so everything from electrolyte balance to orthostatic hypotension, etc., are lurking in the background there. So I'm more. I didn't want any of those to get out of control and sneak up on her and cause a fall or whatever. So I would work on her morbidity issues there, though they're not blatantly severe at this time.
Right. Dr. Breakey.
I agree with the majority on what matters, although this was a harder one because just like the pillars of lifestyle medicine, they're all important. And I like this way of thinking about it, though. So thanks for bringing this out with respect to this case. And in my mind, that kind of first one is what leads to her ability, her desire, her kind of desire to stick with it and do what it will take on the other areas to make a difference in her life. Clearly, COVID had an impact on everybody, and I assume you said she's virtual church now. I assumed that prior to that she was in person and gained a lot from that, and it sort of stuck because so many churches, so many community groups, it was just easier to continue virtual. But I think that's having a toll on people. And I'm glad that she's willing to think about what she can do to make what matters and purpose important for her, in spite of the fact that she's a widow. I do appreciate that the family is still very important for her, and their connectedness gives her drive.
So you went with what matters, correct?
Yep.
Dr. Clapper went with multi-morbidities. Dr. Sunderman, what did you go with?
I chose something different. But I agree with what they both said. I went with medication, and
that's what I went for.
Yeah. So we're all saying the same thing in that they all influence, like one M influences the other M. And so I chose medication because so often when we get new patients and they are older, they've got a collection of medications, right? And trying to figure out, A, do they need to be on all these medications? And B, what are the possible side effects that we're getting from this? And so just looking at, Dr. Clapper said with the amlodipine and the losartan, I think it was, she was on an ARB, I think. And, yes. Could that be causing orthostatic hypotension? And could that cause dizziness that then is affecting her mobility and her risk of falls? And the amitriptyline with the anticholinergic effects. And then she was occasionally taking ibuprofen. Does she even know that that's can not be good for stage 3 chronic kidney disease? So really looking at these medications first to decipher, does she need to be on all these medications to treat the chronic disease, or could some of these medications be worsening the chronic disease? And trying to risk stratify that to see if we can possibly deprescribe or do some education behind that, because that could affect her mentation with the anticholinergic, could affect her risk of fall, and ultimately, what matters for her is her mobility. So that's why I chose medication.
Interesting. Dr. Wagley, what would you have chosen on this list?
So of course, as everyone mentioned, all of these are so important, right? But in primary care, we saw shared decision making. So at the moment she heard about what are the possible risk of anticholinergic medicine like amitriptyline, she really wanted to get off of it very quickly. She at the outset, she said she didn't want to do a whole lot of prescription medicine. She wanted more holistic approach to her healthcare. And so when we talked about medication side effects, she found that amitriptyline can lead to constipation, dry mouth, mobility issues, fall, chronic use can lead to cognitive impairment. She immediately jumped into, okay, I need to get off amitriptyline, and less is more. So for her in particularly, we really, that was a really low hanging fruit to work on.
Mm-hmm. Great. All right, well, thank you for that discussion. Proceed, please.
Her vital signs were it's unremarkable. There's some drop in systolic blood pressure, 120 in sitting and 103. I love to do orthostatic vitals for every patient in older adult in my clinic. So it's a quick way to figure out if they are at risk of fall, if we need to work on any medications. And she had kyphosis in upper back. She had some bunions. She had bilateral bunion in feet. So in our first visit, we worked on weaning amitriptyline. We talked about sleep hygiene. it looks like the pain is one of the reasons for sleep insomnia. So we talked about taking acetaminophen at night. She had a osteopenia in prior DEXA scans. We talked about eating more healthier whole foods, beans and greens, and also remaining physically active with balance, resistance, and aerobic, some exercise at home. We talked about watching blood pressure, and if there's any dizziness with orthostasis symptom, to cut down on amlodipine. We talked about monitoring lab, avoiding NSAIDs. She had hearing impairment, and she is eager to see audiology. We talked about doing some bowel movement diary and dietary changes, including introducing fiber. We talked about how we can address our urinary urgency and urge incontinence by just reducing refined sugar, flour, decreasing caffeinated beverages, and just changing the timing of what she's drinking throughout the day. And we can see this, we based on, you can see how the 5M approach and lifestyle medicine pillars are really part of all this plan for her. A month later, about 6 weeks later, I met her again because she had a fall about 2 weeks after we met. She had a low back pain and hip pain after the fall. And by the time we met, she was completely off amitriptyline. There was tenderness in the spine, low thoracic, upper lumbar area. And X-rays showed L2 compression deformity with 30% height loss. She's eager to do, she's very agreeable to do some physical therapy, some conservative management for pain, lidocaine patch. She had a prior good response with tramadol, so she wanted to take it for if it is too severe. And we also discussed that clinically she has osteoporosis, and we talked about the treatment. And subsequently, she had another fall trying to get off from couch, and it really exacerbated her back pain, and she ended up going to emergency. At that time, she had the clinicians in emergency found she has urinary incontinence. They did an MRI. There was no cord compression. There was recent appearing compression fracture at L1 and L2 with mild retropulsion and mild spinal canal stenosis at upper L2 level. There are multiple degenerative joint disease signs. And she was admitted, and she was discharged home with thoracolumbar sacral orthosis, pain management, and discussed osteoporosis management, which she was very skeptic. She heard a lot of information about osteoporosis treatment, and she was very not eager to be on board with medication. She eventually underwent kyphoplasty for those compressed vertebra. And in subsequent visit, we discussed about treatment for depression. And we continued physical therapy, sleep hygiene, osteoporosis management, pain management were part of the future subsequent discussions, while we continued to promote the lifestyle pillars in interventions. And later in the November 2022, when I saw she was still doing physical therapy, she had to make some progress in her diet. But she was taking 2 tablets of acetaminophen, diphenhydramine, because her sleep issue was more a problem, and she didn't tell us until we met in November. She was introduced melatonin in spring, and that was not helping, so she just went to over-the-counter Tylenol PM. See some positive things. She started to hang out with the church friends, and family are more in touch, and she said her depression is better. And we continue discussing osteoporosis management and pain management at that visit. This year, just to give a quick snapshot, she is now optimally eating enough amount of fiber in a day. Over time, she found herself, which some of the fiber sources were caused more GI bloating, and she learned which is she's more comfortable with, and she's having regular bowel movement, and she started to completely started routinely schedule bowel movements before going out, and her fecal incontinence decreased significantly, and she was really happy with the success. She had to be, and we started on trazodone, low-dose trazodone, and she continued her acetaminophen at night, along with sleep hygiene, to get better sleep, and she was sleeping better. 7 hours for majority of the week, and some days she's still sleeping 4 or 5 hours. She minimized her screen time before bedtime, and she really followed a lot of sleep hygiene strategies. And she was ready to go back to her fitness center, and she was particularly interested in balance class the fitness center was offering. And some of the quotations from the last visit was, she did not want to snack on any processed food anymore. And she asked me, is it normal to have craving for healthy food all the time? That was her question. And she even asked me, how can she learn to even add some more flavor to black bean soup? And she said she's now walking to the church and going to fitness center 3 times a week. I just spoke with her this afternoon again, and she has been continuing to be excited about all the changes in diet and sleep hygiene. So her sleep is much better. Bowels are much better. She has been starting to do some activities with her girlfriends, to go out to the park or museum, etc. And her overall, she has been sharing how this approach has been very helpful for her. I'll definitely have a lot of room to discuss, but I just want to highlight there were several geriatric syndromes for her. One is altered bowel habits, urinary incontinence, insomnia, social isolation, osteoporosis, and polypharmacy. And all were, and we can see, and she endorses how all the lifestyle medicine approach has addressed, at least all of the geriatric syndrome to some extent. And this was really exciting in a way. So I'd like, in the next few slides, I just wanted to review some of the strategy I do to incorporate these tools in the practice, and then we can have more room for discussion. So as I mentioned, I do the 5M assessment to all patients, and we also do lifestyle vitals assessment to assess for lifestyle pillars. And we use lifestyle medicine prescription pad, and use understand where the person is in behavioral change before making any changes. Utilize a motivational interview, positive psychology approach, use a SMART goal and FIT strategy for exercise. And for social isolation, we based on what person's need is and interest is, we work on those with the help of our interdisciplinary team. And handouts, we based on what person's needs are and what is the lowest hanging fruit for particular situation. We use those handouts. Mrs. Hoosier's favorite handouts is the ACLM's grocery list. We provided her this in the first or second visit, and she said she pretty much went to the grocery store and collected some of those and then looked into how she can incorporate in her daily routine. And that is how she started, using more of the recipes out of these whole food plants. The second handout she really liked is this Optimum Fiber. This is from a GI group in Georgia, and it really has a nice table in the back that gives some idea about how much a cup of navy beans has, how much fiber it has, and all others. So it was really, she found it very helpful. We use this ACLM's handout for urinary incontinence. She found it useful, especially to seeing the whole picture, like how all the pillars are important to address her clinical concern. We connected her to local. It's really important to know what is your local community resources so you can promote those for your patients. And for her, we did a lot of check-in televisits, like a phone call from our team, nursing, social worker, medical assistant. They checked in a couple times just to make sure she's in the right track and all questions are addressed. We utilize annual wellness visit a lot to really promote overall lifestyle intervention and healthy aging. And an important strategy is the team huddle. A lot of times I won't know what support are there in the community for some patients to address social isolation or all others, caregiver or companionship. And there's always someone in the team that can bring up information. Hey, there's this a local neighborhood club that really helps seniors. Or this is, there's a line dancing program for seniors. And they always, they bring up these resources that I have no clue about and that can really help patients. So team huddle is an important part of incorporating lifestyle medicine strategies. So in reflection, one of the big reflection is it's really good for older adults too. And there's a lot of skepticism in my colleagues about how you can talk about this to frail older adults. But in reality, in every clinical case, I can see how it helps. There are good studies looking at proving the lifestyle interventions in older adults. And the recent, just an example that comes to my mind is a recent Lancet Dementia Commission. One of the conclusions was it's never too early and never too late to promote cognitive health. And I realized taking lifestyle vitals to assess those pillars makes a difference. The moment a conversation starts, it really starts some thinking in the patient or patient's family. And that really opens up the door for further intervention. And I also realized how much I underestimate a patient. 5 years ago, I would not understand. I would probably totally underestimate what a 85-year-old frail old adult with such a poor social support can change in their daily lifestyle. We really need to understand where the person is and be able to change. I got lucky with Mrs. Hoosier because she was already motivated. She wanted to minimize prescription medicine, and she really wanted to stay on top of the health. And we really engaged. She was really engaged in our conversation, so that was really helpful. And I see the ripple effects. I see every time I speak her, including today, she was saying how she's here, the benefit with her church members, with her friends. And she's passing the recipes and etc. And then support and follow-up. We cannot really intervene and not follow up and not provide support. And that's where the whole team can help the follow-up. There's a few references that talks about geriatric assessment. And there's an easy pocket card for 5 M's. And I want to request everyone to look out for this chapter by Dr. Muniak on textbook of lifestyle medicine on how geriatric principle and paradigms can inform lifestyle medicine practice. All right, that's the end of the presentation. I'm sorry I rushed through the case, but I didn't, so it's open for more discussion now.
So that's great. Thank you for that tremendous and inspiring case. I don't know where to start with our panel of experts here. I think I'm going to have Dr. Clapper go last, actually. So he'll be, so let's hear from Dr. Sunderman.
So thank you so much, Kamal, for that amazing case. And you're absolutely right. It is never too late, right? In small changes. And I think this is just, you were able to show that lifestyle medicine is applicable to everyone. And so often I think maybe a not lifestyle medicine geriatrician would take the symptoms that she was having and even medicate more, right? You're feeling lonely. Okay, let's add an SSRI onto that. Oh, you're still having trouble sleeping. Let's increase the amitriptyline or add something else. Oh, you're having some bowel things. Let's give you a medication for that. Urinary things, let's get a medication for that. And so what you were able to do is say, wait, let's look at, the 5 M's. Let's take a bigger picture. And I think what I want to call her Mrs. Wolverine. We have 2 U of M grads on here. I know you're from IU, but I'm going to say Mrs. Wolverine. That she proved that she was an elder, right? So often we think about elderly and being frail, but she was a modern elder, right? Because she was able to take all of this in, make some small changes that were significant and are going to improve her well span, right? Will improve her lifespan as well, but her well span. And that's what really matters to her is family. And now she's going to have more time with family and her mobility. And so I just am so grateful to have geriatricians like yourself. I know Susan Friedman, that's also her specialty, because we don't want to ever give up, right, on our patients. And who would have thought an 85-year-old now has a whole new lease on life and is on fewer medications and is empowered and is learning and is curious. And I just am really grateful for what you've been able to do with this woman. And I think that one thing you did mention was some hearing loss. And I think with our older patients of really realizing that sensory deficits as they get older can be really large risk factors for dementia. So if there is any hearing loss, really encouraging our patients to get hearing aids. And nowadays, I mean, you can barely even see them. So just to encourage that they get that to maintain that cognitive ability. So thank you again.
Yeah, thank you for those remarks. Dr. Brakey, your thoughts? And you are muted.
Just want to also emphasize that she's very fortunate to have you as her doctor. So often patients of this type have, it just gets compounded by the medical system that focuses on treating symptoms rather than getting to the root cause. So great case, a great example of what John McDougall talks about is, well, everybody gets better. And that doesn't mean that everybody gets back to perfect like when they were 18, but it means that when you change their environment from inflammatory to anti-inflammatory, when you get them to sleep that allows them to better repair and restore, when you get them the connectiveness that gives them purpose to stick with it, when they start moving and doing more, they improve from wherever they are. And I had a great similar example. This is I don't know if you can see George here. He said I could share his story. He was 84 when he came in just beaming one day. Now, I'd known him for about 20 years, but he came in just beaming. I said, George, what's going on? He said, Doc, I watched that Forks movie you gave me. And 4 months ago, I went plant-based. And he said, I feel great. All that digestive symptoms I was having, my arthritis, his cholesterol dropped significantly. He got off his amlodipine and his pravastatin, and his blood pressure and cholesterol were better than when he was on them. But it was not easy. He's 84. He's from Kentucky, where they ate a lot of things that he shouldn't have oughta. But he listened. He had readiness for change. And then he felt the benefits. It's now 6 years later. He's living in assisted living now, but he's still doing well. And that's what inspires us as lifestyle medicine practitioners to be able to say, yes, it takes longer. I may not make as much money. Sometimes I get yelled at for being radical. Sometimes my colleagues think I'm not, giving them the full benefit of what modern medicine has to offer. When in reality, we're giving them that plus. We're allowing folks like your patient and George and others in this age group to manifest their full potential even well into their elder years. So great job on the case, on presenting it, on what you've done for her, and I'm sure countless others. Thank you.
Thank you, Dr. Brakey. Dr. Clapper, any comments?
Yes, starting with a big thanks. Not only was this beautifully presented, but when I went into practice 50 years ago, if Mrs. Hoosier had come into my office, you have to fight down the urge to run out of the room screaming, because I didn't know how do you handle these people at the end of their lives with a zillion problems. And what you've done is given us this beautiful framework. So step back. Here's 5 things that really matter to both the physician and the patient. Go through the 5 M's. Now we got a framework to work in and to see what really matters here on every level there. And so that alone was just a supreme gift. It really makes me feel more confident dealing with patients like this. And so thank you for that. My only Ms. Hoosier is an ideal patient, and she had her issues were amenable to the therapies you recommend. In the patients like her that I run into, there's the 2 major obstacles I run into are, one, they're living in an adult care community and they have no control over their food. Whatever they're given down in the dining room, that's what they got to eat. They're an 85-year-old lady. They're not going out doing their own shopping. So they eat the scrambled eggs for breakfast and the cold cuts for lunch and the mac and cheese for dinner. And you talk about changing their diet and they roll their eyes as, what do I do, doc? So I'm curious what you do with those folks. And the same one, she's on a little amitriptyline for depression, but I've got 3 daughters. 2 of them live out of town. 2 of them don't live here. The one who does live here, doesn't like me. We've been at each other for years. I'm depressed. I'm lonely. She never comes to visit. So what do you do when they have no control over their food and their family is not supportive? How do you start making some progress there? I'm curious what's your approach?
It's a great point. First of all, just to highlight the 5M approach and comprehensive geriatric assessment. Really, we assess what are the sensory impairment or what is important to patient. So when I talked to her today, she said she was able to make a change because she really believed in our team. She felt like she is really engaged and we are really genuinely passionate about her health. And I was reflecting, I think that is the most crucial part. I think probably the 5M approach or just the relationship. Once you really establish a good relationship with the patient, I think it really starts, then the next step will be easier. So that was, I just wanted to mention. And to your question, I get to work in some of the skilled nursing facility and long-term care where just like you mentioned, the diet is not optimum. And we get to work with the dietitians. And obviously there is always standard menu and there's always choices. And there is also this patient has a right to choose which food they want to choose. So although the recommendation is there's always, for example, a bean soup or some steamed vegetables, a patient can choose more processed food if they would like to. So and it's a part of their patient right. So there's always a more importance of really engaging patient first. And recently I get to learn from that's for the patient who are residing in the senior care communities like a skilled nursing, a long-term care, or assisted living. Even in those situations, if we engage patients, like there's always they can choose for better choices. And obviously the leadership also can start to introduce some nudges, how we can really highlight the healthy food and not so highlight the other food options and so forth. As far as community older adults with variety of social determinants of health, I learned there's so many food banks and area agents in aging that have a lot of projects and programs For example, right now in Indianapolis, there is for every patient who meets a certain multimorbidity eligibility, the area agency in aging can send a monthly delivery of produce that includes vegetables, fruits, beans, and so forth. So I was so impressed. So a lot of times we won't have an answer as a clinical provider, and we just need to bring it up to our social worker and team. I think there's always some resources that can potentially be added, is what my experience has been. But absolutely good point. Thank you.
Interesting. Well, we have a couple minutes left before the official ending here.
Ted, I wonder if Dr. Klaper could comment a little on the osteoporosis. I saw a recent article he wrote on this and sort of the underlying etiology and what she might expect. Could it be partially reversed?
Yes, osteoporosis, in my viewing, is largely disuse atrophy of the bones. If you stop bearing weight, then nothing stimulates the osteoblasts, and they start losing osteoid and bone mass there. And so any osteoporosis reversal program, along with a healthy diet that you have around, has to involve something that stresses the bones, whether it's elastic bands or doing weights while she's sitting in the chair, doing something, squats while she's supporting herself on the chair. But she's got to start using those bones. So physical activity is really key. And so we want to encourage her to do that, especially a little bit of weight bearing as well.
Yeah, I couldn't agree more. I have my own set of, I used to go to the gym all the time until COVID, right? And then I just invested in about $30 worth of rubber bands. And you can do an incredible amount of exercise. The only thing is, if you're a numbers person, it's really hard to like write down what you just did because, right? Uh-oh, I'm having a bad time. Is my video a little glitchy here?
No, you're good. Oh, okay.
Yeah. Anyway, it is what we're going to do now is we're going to officially call this to an end. Thank you, everybody who stuck around, and you will receive an email in the next 30 to 45 minutes with a link to a survey. Please fill out the survey, and you will, when you get to the end, hit submit, and then we will send you a certificate for worth 1 hour of CME. We've also added a question to the letter you'll be receiving, asking if you're interested in helping us with our new social media platform called OnePaleBlue.earth. We're looking for contributors in fields of medicine. Dr. Sunderman has her own group for nature as medicine. The whole thing has not been officially launched, but we're building this in the background. And there's going to be a group for people who attend Lifestyle Medicine Grand Rounds as well to just continue to discuss these important cases. So please, if you're interested in helping us with that, just let us know and when you respond to the email. So I'm going to officially adjourn. After one more thing, Dr. Klaper, would you like to have one final thought on how we handle our geriatric patients?
Have compassion for them because you're going to be one sooner than later. As I looked at this old woman, I'm actually 7 years older than I am, and so as the years go by, I'm getting more and more compassion for the geriatric patients. So treat them all with respect.
All right, well, yeah, right, and thank you for that. Our next Lifestyle Medicine Grand Rounds will be July 11th with Drs. McDougall and Dr. Klaper. What's the word? A plethora of riches. There's another word I wanted for that. But anyway, so we're going to officially say goodbye, and then we're going to invite the people who have stuck around in the audience to turn on their videos and ask any questions they might have. So is anybody in the audience? And I see Deborah Kelly's clapping. You know what we're going to do? We're going to ask everyone to unmute because we have people from all over the world here. So we're going to unmute and shout hello. So when I count to 3, so get rid of those little red microphones, please. On the count of 3, 1, 2, 3. Hello.
Hello.
So glad you all stuck around. And turn off. Okay, great. Let's see. Wonderful presentation. Looks like Kira Conrad has unmuted herself. Did she have a comment or question? No. Okay. Deborah Chieli, I know you always have important things to do. I know you just had did a stint at some nursing homes recently. Well,
yeah.
What was that experience like?
It was very sad. I took a very brief stint with a Medicare Advantage insurance company, thinking that possibly I could make a difference. They thought that I could make a difference there. They saw my resume, and I know that ACLM is partnering with Humana and some Blue Cross Blue Shield carriers. So I thought, okay. But it was very, very disappointing in terms of the quality of care, and also the insurance company getting in between. There's a doctor assigned to the patients, and then the insurance company can actually override that physician. And so it's like this double-headed care, but they call it a bypass, literally. I witnessed where the doc, we had a patient that was really advanced heart failure, and she said, I'm feeling faint just talking to you. She said, I want to go to the emergency room. The nurse told the doc said call 911, and the insurance company called in and said, what's going on? If the paramedics are there, tell them that they can go, and if the patient's been sent, call the paramedics and pull the patient back. They can be treated in place. So I really witnessed something that was really pretty stunning.
Mm-hmm.
Based on my ethics, I couldn't stay. And I really feel that there are articles, I know they're writing about this, but it is a huge issue. Very dedicated staff there, the nurses and the team on site, really doing yeoman's work, really, really caring about those patients there.
Mm-hmm.
A lot of things that weren't yet being done in terms of just like the standard of care in terms of guidelines. I saw a patient with advanced breast cancer. They didn't even know when she had her last mammogram. A patient with advanced MS. So we just saw a lot of very sad things, and I just couldn't fix it. I'm sorry. I probably
That's okay. No,
yeah.
Thank you for sharing. Dr. Wagley, do you work much with nursing homes?
Yeah, for this 1.5 year, I'm working on this new value-based care model clinic, and that needed my full clinical effort. So I paused my nursing home work. But previously, for 7 years, I was in a nursing home, and it's really fascinating place to work. I know there are definitely some incidents, and it's also a very, I would say, sort of a neglected part of the healthcare system. There's a poor communication from hospital to nursing home to clinic, community, like primary care clinics. But there's so much of low-hanging fruits. Like you can definitely work with medical leadership or administrative leadership to make changes, and these are very rewarding. Like, for example, I get to, as a medical director of nursing home, I get to work with the hospital system to improve transportation, so patient will arrive on time, like early hours in the nursing home, so we can make a care plan. Otherwise, the hospital will discharge patient late in the hour, like 6 o'clock, 7. They're not really prioritized. And when you reach late night in the nursing home from hospital, the care is always chaotic because of the staffing. And so overall, I see the nursing home as a whole lot of really a place to do a lot of process improvement, and really make a difference. It was very rewarding to see what you do can affect the quality of life of residents so quickly. And just like I mentioned, it's really a place to work with the physical therapy and administrator and dietitian and recreational director to incorporate a lot of some of the lifestyle medicine tools, like also like improving mobility, getting the patient out of the bed, taking them to a community room, or encouraging everyone to dine in the dining room instead of, eating food in their isolated in their own private rooms and so forth. So yes, there's complexity, just like Deborah mentioned, but I think there's also a whole lot of, it's a place to really make a difference also.
Yeah, no, thanks for that. So we have a question from Dr. Miner. Do you know of any facilities that care for geriatric and multimorbidity patients with lifestyle medicine or a lifestyle medicine-like approach? Are we making any progress out there in the field?
I can't think of any right away, but as you see, there's so much of, as me and I was talking to Susan Friedman, and it's a lot of geriatric and Jennifer Muniak also, how the principle of geriatrics align so well with the lifestyle medicine. But I've seen there are a few geriatrics clinician leadership in the hospital and healthcare system, and I think I can see that they are moving the needles on progress and there's really more engaged medical director who is making a difference in their senior care communities like assisted living. So I can't think of any 1, 2, 3 industries per se, but I think we will be seeing them as things are evolving also.
Just wanted to add, sorry to interrupt that question. I'm going to put in the chat. I did a talk oops, that's not what I wanted to. It's for the Health Resources and Service Administration, which is government, and they give away, not that they give away, you have to apply for them. Hold on, let me just put this in the chat, for geriatric academic awards. And when I spoke with the group, so these were the grant awardees, and actually Susan Friedman is very much involved in that. And a lot of these grant awardees were very interested in lifestyle medicine and pursuing both research and academia and as well as clinical research and practice of lifestyle medicine in the geriatric population. So I think there is progression going on. I know that Susan's really involved in that world. And then these are grant fellows that are actually applied for grant money, seeded money to expand this.
Right. Yeah. Thanks for sharing. Yeah.
So I have a question.
Oops, I'm sorry. Go ahead.
So actually, I have a question. So I missed the very beginning of the talk, but what drew me to this event was that I am a diabetes care and education specialist. I'm an exercise physiologist, and I have Dr. Furman's certification in teaching plant-based nutrition. So this is definitely my forte. Anyway, so I have a new patient who is 100 pounds, soaking wet. She's early 80s, and she has an elevated A1C. She has an elevated fasting blood sugar, mildly elevated cholesterol. Certainly for us, it would be elevated. So in the back of my mind, I'm thinking that she has some sort of type 1 diabetes, latent autoimmune diabetes in adults. So she is plant-based or has been not so much on target in the last year or two. Her husband passed away. So I asked her to see an endocrinologist whom she did not have. So she established with a new endocrinologist. The endocrinologist was not interested in her C-peptide, in her diabetes or antibodies. So the fact that you were going to be rounding on an elderly woman who was thin and frail, and that just sort of was a red flag in my mind. Is that something that you think about when you see this phenotype?
Right. So you're.
Thank you for bringing that point. So I really haven't thought about that, and I didn't recall her A1C and glucose levels are, but thank you, Peggy, for the reminder.
Yeah, sure. It's a really good thought. Dr. Starnowski Roberts has had her hand up patiently, and then I think we're going to call it after that, but go ahead.
Yes, I have a question for you. I have worked in the emergency department most of my career and only recently have been doing some lifestyle medicine. But the thing that I saw most often in the emergency department that was upsetting to me is the elderly person who falls and can't get up. And then you have all the issues with getting prior approval for them to even go to a nursing home and get rehab. So the point that I have is that it's so important for people to do strength training. And probably not the time to start it is when you're 80. Probably the time to start it is when you're significantly younger than that. And I think we should be pushing that on even younger patients to make sure you're doing strength training. Do you have any other advice to help prevent these poor patients who help me? I fell, I can't get up.
So I think there are 2 points. One is to promote these exercises. And I put a part of my template in my progress note, and initial assessment is to assess these lifestyle pillars. So by default, it really gave an opportunity for me to at least mention that here there is, what exactly what exercise are you doing, and how this is important, and to inform the patient and family caregivers. And also I saw some Medicare Advantage comments, and noticed that some of the Medicare and Medicare Advantage or various insurance, they also have the Silver Sneaker program. They get a free membership or discounted membership to a fitness center, or they may get a free personal trainer. And I really encourage them to check that out. And until before, when I didn't have that part of my regular template, it never come into the conversation, because there is always clinical concerns to talk about, and focusing on preventative physical fitness was always ignored. So I really like your point of promoting all the aerobic, balance, resistance, all 3 forms of exercise for everyone, and also to check what benefits they can get from insurance, and they may already have some more benefits, so they can enroll in fitness center. That's part one. The second comment about this helping older adult get up, and overall, I think it's a big issue. That's why the AIDS-friendly health system initiative is if you look at the AIDS-friendly health system of IHI, there's a whole lot of healthcare system signing up, getting trained, getting certification, getting a more of a AIDS-friendly health system certified center. And the whole point is every team member of the healthcare system, that includes the front desk, receptionist, security, all our therapists, physicians, clinicians, they are all aware of this 5M approach for the patient. So how can we improve mobility? How can we provide safety? Is this bathroom in the clinic, is this appropriate for someone who has significant osteoarthritis? Is all of those things, and it became ingrained into the structure, engineering, and framework of all the team members. I think that is more of a sustainable, long-lasting solution to exactly answer your question. But I know that we probably may not be a quick fix, but I'm really excited about this whole geriatricizing the whole healthcare system with this age-friendly, framework.
So I'm not familiar with geriatrics, but you had one of the tests that you do is how quickly, I guess, somebody can stand up, get out of a chair or something.
Yes, yeah.
So when I have people, they're sitting on the edge of the bed in the hospital, and I ask them to stand up without using the bed or anything, they can't do it. So is that test where they're able to assist themselves in getting out of the chair by putting their hand on the chair or on the, arm of the chair, or is that testing them to see if they can even get up without any assistance? Because this is all new to me, but this seems like a huge problem.
Right. So it looks like where you practice is more of a more acute, acute clinical setting. And if the person is not able to get up from the chair, then there's, of course, no point in doing that test. The person is already have impaired mobility. And in some of the emergency centers and inpatient, when we round, we also often ask them to consult physical therapy so they can come and provide assistance or help with the care plan. right at that moment at the point of care. But this test, time up and go, is very valuable in other setting, like outpatient setting, a little bit more upstream, where we can proactively look at person's mobility. It's a part of the CDC fall prevention program, and it takes only, it doesn't need a licensed person to even do it. You can ask any of the team member in the clinic to just look at the timer and get this test done and provide the information, so it can be part of the plan for the physician.
But do you allow them to press on the seat to get up, to help them to get up?
No, they should be getting up without assistance, without getting up. Yeah. And walk for 10 feet and have a seat again. And
so, just so you know, like physical therapists, you can order it.
Yeah.
They may come once or twice a week in the hospital. So when I go around, I make people do this with me. I make them sit, stand, sit, stand. I have no idea if I'm doing it right, wrong, or the otherwise, but it's something, and I'm encouraging them. I mean, I don't know.
Absolutely.
So I just think we made a big mistake in this country and not getting 50 and 60-year-olds to start working on strength training.
Yeah, interesting. Well, this has been a great discussion. Thank you, Dr. Sinaksky-Roberts, and also thank you to our panelists, Dr. Michael Klaper, Dr. Melissa Sunderman, Dr. Robert Brakey, and especially Dr. Wagley for the work you did in preparing the case, because you had the hard job. Everybody else got to have fun, but you did the actual heavy lifting. And thank you, Deborah Chieli, for sticking around and for being part of our Rochester Lifestyle Medicine Institute team. It's great to have you on board. And we will see you all July 11th when Dr. Klaper presents a case to Dr. McDougall. So thank you all and have a great night.
Thank you.
Yep.
Thank you.
Thank you. Well done. Well done.